Welcome to RNM Mindset Prep. Today, we're going to look at lithium toxicity and why stable patients can become critically ill without any change in their dose. Here's what makes lithium dangerous. It has a narrow therapeutic index, meaning the gap between a safe level and a toxic level is razor thin. Dehydration, a new NSAID, or a diuretic can push a therapeutic dose into toxic territory overnight. The tricky part is this. The symptoms of lithium toxicity look almost identical to a psychiatric episode. Confusion, slurred speech, coarse tremors. If a nurse assumes it is the underlying illness getting worse, the real problem gets missed entirely. Scenario 1. A patient with bipolar disorder on lithium for 3 years is brought in confused and trembling. Staff note she recently started ibuprofen for knee pain and has been poorly hydrated. The nurse needs to act now. Option A. Reassure the patient and notify the psychiatrist about a possible mood episode. Option B. Restrict fluids to prevent worsening confusion. Option C. Check the lithium serum level immediately. Option D. Administer a PRN antipsychotic medication. Let's break this down. Option A is incorrect. Assuming this is a psychiatric episode without ruling out toxicity first is dangerous. The physical symptoms demand a physiological explanation before any psychiatric label is applied. Option B is incorrect and actually harmful. Restricting fluids in a patient who may already be dehydrated would concentrate the lithium further and worsen toxicity. Option D is incorrect. Giving an antipsychotic does not treat lithium toxicity and could mask the clinical picture even more. The correct answer is option C. Check the lithium serum level immediately. When a patient on a narrow therapeutic index medication shows neurological changes, the nurse must think drug toxicity first. Checking the level is a fast, nurse-initiated action that confirms or rules out the cause. In this scenario, the level came back doubled, confirming toxicity. Scenario 2. A patient on lithium is admitted after starting hydrochlorothiazide 2 weeks ago. He now has a coarse hand tremor and is difficult to rouse. Option A. Hold the next lithium dose and obtain a stat serum lithium level. Option B. Reorient the patient and monitor every 4 hours. Option C. Prepare to administer a benzodiazepine for tremor control. Option D. Increase oral fluid intake and reassess in 1 hour. Option B is incorrect. This patient is difficult to rouse. Routine monitoring is not enough for an altered level of consciousness. Option C is incorrect. Treating the tremor without identifying the cause delays the real intervention and could further sedate a patient who is already unresponsive. Option D is incorrect. Oral fluids alone will not correct a toxic lithium level, and a patient who cannot be fully roused may not be safe to drink. The correct answer is option A. Hold the next lithium dose and obtain a stat serum lithium level. Diuretics reduce sodium, and the kidneys respond by retaining lithium in its place. This is a well-known drug interaction that can turn a stable patient toxic within days. Holding the dose stops further accumulation while the level confirms the diagnosis. The key takeaway is this. Narrow therapeutic index medications require a different level of thinking. When a patient on lithium, digoxin, or warfarin suddenly looks worse, always ask whether the drug itself is the cause. The most dangerous toxicity is the kind that looks exactly like the disease you are already treating. See you next time on RNM Mindset Prep.